Good afternoon to all of you. At the outset, I sincerely thank my madam, Yasod madam, as well as Vijaykumar sir and Dr. Sudesh, and the whole team of Moa for inviting me to take part in this. I think we have three great training sessions on neurological case and then nephrotic syndrome and the area of SAM. So probably all of you are probably tired, eagerly waiting for the next, and probably we'll have a very brief discussion on the other side of malnutrition, that is the malnutrition. So we'll have a very brief discussion on it.
Good afternoon, sir. Good afternoon, everyone. So, I'm Apsara. This is Sabrina and Kavya. We are here to present a case on obesity. Master Darshan, an 8-year-old male from Kurukshetra, was brought by his mother, who is a reliable informant, presented with the chief complaints of excessive.
So this child is coming to the OB. How will you describe this boy? He is coming to you for a fever. Generally, children will come to you normal complaints of overweight. They may come to you with some other symptoms, isn't it? They may be having fever, cough, rhinitis, etc. Okay, so yes. So what is the first message we should learn? You should have a comprehensive assessment of the child. Don't have a tubular vision. When the child is coming to you, just see the child as a whole. Isn't it? Because they will not come to you for obesity or overweight. So they may come to you with many other symptoms, but just as soon as you see the child, you should assess his weight, and if he is overweight or obese, you should specifically tell the man to keep them under follow. Don't send them for the
parents likely support.
yes. Okay, and you have to see the family as a whole. Okay.
The chief complaints of excessive weight gain for past 2 years, blackish pigmentation on the back of neck for the past 6 months, abdominal pain for the past 1 week.
Okay. So what are the things that are coming to your mind? 8-year-old boy coming to you with complaints of excess weight gain of 2 years. Anybody? So there is a reason. Recent onset in weight gain, isn't it? Then second, there is blackish on the back of the neck. What could be that? Back is significant. Then abdominal pain. What could the cause of abdominal pain in this child? You have got any PG? Yeah. You can volunteer. Cause of abdominal pain for this child is overweight or obese. Fatty liver. Okay. Anything else? Anything else? Okay. Constipation. Okay. So I got a child with constipation and overweight. What do you suspect? Okay. Hypothyroidism. Right. Okay.
History of presenting illness. The patient was apparently normal 2 years back, after which he developed excessive weight gain for the past 2 years. His mother noticed him gradually starting to put on weight from 6 years of age. History of
any previous any comment on that? For you it is okay, but in pain, adiposity reborn, any PGs? Have you heard of the name adiposity reborn? UGs? No. Yeah.
3 years to 5 years back, adiposity.
That's a big thing, adiposity. Yes, you can sit down and
There will be a dip in the adiposity from 2 years to 5 years. Mother usually notices that the child is not gaining weight properly and also. After that only, after 6 years there will be a normal weight gain.
So generally, children likely to be a little bit overweight in the first group in the infants, isn't it? And then they have a thin lean mass, and maximum leanness comes by about 5.5 years. Now for that there is again increase in the fat deposit, isn't it? That's called adiposity rebound. Okay, right.
History of hyperpigmentation on the back.
And I request all of them are international speakers and very experts. So I request all of you to give our expert comments also in between.
History of hyperpigmentation on the back of the neck for the past 6 months.
Yes, I think let us welcome Dr. Diaz. He's Professor Pediatrics and Assistant State President of Indian Academy of Pediatrics, Kerala.
History of abdominal pain for the past 1 week, which was insidious and onset, present in the lower left abdomen, non-radiating with no vomiting and fever. It was a constant dull aching type of pain. History of snoring, mouth breathing and restless sleep are present.
Okay. So, what is that? Snoring and mouth breathing. Severe sleep apnea, right? I don't know what's up. So many areas of lymph node hyperplasia. Lymph node growth is maximum between. Any idea? You should do 4 percentage. One is somatic growth, second is brain growth, third one is lymph node growth, and fourth one is isn't it? Or if you please go and read 4 types of growth. That will be asked. Okay, right.
History of constipation present. No history of head trauma. No history of polyuria polydipsia. No history of hyperphagia. No history of pain in hip joint. No history of knee pain or in toeing. No history of nervousness, school avoidance or social inhibition. No history of drug intake. No history of headache.
So she has specifically mentioned some symptoms. That means she has thought of all these causes or all these different diagnoses as a cause of obesity. Okay. So can anyone tell history of constipation and obesity? We already said to be hypothyroidism. Then we know history of trauma. Why? Anybody? Please. Can we do leading on to nations and cantons? Okay, all right. Then, polyuria polydipsia. Diabetes? Diabetes mellitus. Okay. Then hyperphagia again saying, then pain in the hip joint. Why? Please. What is the so you are thinking of the various complications of comorbidities of obesity, isn't it? Why you are saying there is a pain in the hip joint? Arthritis. It's only 8 years, not 50 or 60 years. Hip joint, knee joint, pain. Sleep capital femoral epiphysis, isn't it? What is Crohn's disease? Have you heard of that? Crohn's disease. For you, features is all, allegiance is all.
Proximal tibial.
Okay, right. Then he has specifically said no of nervousness, social avoidance, social inhibition by
Psychology.
Yeah, because all children with obesity, at least many children with obesity will have some behavioral issues. They will have poor self-esteem, even sometimes they may go for depression. Okay, so again the message is comprehensive assessment.
Lot of body shaming and bullying may be happening in school.
So it is biopsychosocial model. Always you think of a psychological and social issues also. Whenever you come to a childhood Any problem? Okay, right. Right, okay.
Physical activities active during school hours. At home, he sits and watches mobile and television for prolonged period and is mostly inactive. Average screen time duration is 5 to 6 hours per day.
Oh. So what's the comment on this?
Second.
What is the screen time recommended for children less than 2 years? No screen, isn't it? It's not 1 hour. It is no screen, it is 2 years of age. And after that, maximum recommendation? How much? Okay, maximum 1 close.
Less than 2 hours in school.
Okay. Then it should be the maximum. Maximum is 2 hours. Okay, it should be restricted to at least 1 hour per day. But here child is observing seen for 5 to 6 hours.
We have
Okay, right.
class academic and non-academic screen time. Because
No,
some
online class.
children have online tuition and all now. Online tuition.
Right.
Birth history, antenatal history, first trimester, second trimester, third trimester, uneventful. Natal history, cried immediately after birth. No history of birth asphyxia or prolonged labor. Birth weight 2.8 kg. Breastfed immediately after birth. No feeding difficulties present. Postnatal history, no history of hypoglycemia, respiratory disease syndrome, neonatal seizures, neonatal jaundice or anti-seizure motion.
Suppose the weight of this baby was this child was 2 kg. Can you think of something? This child is IUG or IUG. Yeah. So and the child he's 8 years now.
How
and
is
he's-
it related to obesity?
So what is it? Excellent. Marker.
Hypothesis.
Good. Right. Right. Tell you.
Dietary history. For breakfast, we took 320 calories, 58 gram carbohydrate, 4.2 gram fat, and 12.4 gram protein. Snacks, he took 120 kilocalories, and carbohydrate 30 gram, fat, no fat, and protein is 0.2, fiber is 1 gram, and sugar is 28 gram. And then for lunch, he took 320 kilocalories, carbohydrate 58 gram, fat 4.2 gram, protein 12.4 gram, and 5 gram fiber.
I think you can tell the total calories.
See, Horlicks and Oreo biscuits. Show that. Show that. Show that. The previous slide. Horlicks and Oreo biscuits.
Okay.
Okay. Now go to next.
Calories, total calories 2678, which comes as excess in 978 kilocalorie. Protein, his intake is 78.2 gram per day, which is less. And fat, it is 62 gram per day, which is less. Carbohydrate, it is 429 gram, which is excess. And sugar, it is 80 gram per day, which is excess. And dietary fiber, it is almost normal, 16.
Okay, so this is self-explanatory, isn't it? So that shows he has got nearly 1000 calories excess. And he is watching TV for 6 to 8 hours per day. So it is he has got excess calorie intake and he has got sedentary lifestyle leading on to naturally obesity. Right.
Developmental history, attain all gross motor, fine motor, language, and personal social milestones at appropriate age. Studies in third standard with good scholastic performance.
Okay. So what's the importance of this scholastic performance and childhood obesity?
There is no mental
Let your friends,
IQ.
Let your friends answer first. What is the importance of cognition in childhood obesity? Don't use the word mental health, it is intelligent disability. Any others? What are the condition where you will have intelligent disability and obesity? Okay. Yeah, you always think of a syndromic condition, isn't it? Like one example of Prader-Willi. So whenever you have a child with obesity with intellectual disability, please think either it could be a syndromic condition. Right. Can you?
Immunization history. Immunized as per national immunization schedule till 5 years of age. Last taken was PPT booster. No optional vaccines taken. BCG scar was present. Family history.
I think it
Grandfather.
is better to say that vaccines recommended in the IAP schedule not taken. There is nothing called option.
Family history. Grandfather suffers from obesity and type 2 diabetes mellitus. There is no history of type 2 diabetes mellitus and obesity in mother and father. Socio-economic history. Mother is 31 years old and she is lecturer. Father is 36 years old and he is engineer. Income is 87,000 per month. He is a single child. They belong to upper middle class according to modified Kuppasamy scale. General physical examination. The child is alert.
To summarize the history, I have an 8-year-old child who was a normal birth weight, isn't it? And he is having practically 7 activities. And he is only child and they have got nearly 1 lakh rupees of income also.
What food is taking?
And he is taking junk food, isn't it? Junk food. And he is having suddenly lifestyle and watching TV all the always. Isn't it? So what will they, and grandfather is also obese. So from the history, what are your possibility? What's the most likely diagnosis?
It can be constitutional obesity.
Okay, what this could be constitution where obesity can run in families, isn't it? Then
What is a better term for constitutional?
Exogenous obesity.
exogenous obesity. Because and he has lifestyle is also suitable for exogenous obesity. Right.
The child is alert and cooperative, well oriented to time, place, and person. Acanthosis nigricans grade 2 was present, which is confined to the base of skull, not extending into axilla. There is no pallid icterus, cyanosis, clubbing, edema, or generalized lymphadenopathy.
That is what is grade that mistake, no? He has got grade 2 in the neck and he has also in the axilla. That child. You have put both together. How will it extend to axilla? It extends laterally. Axillary also there is grade. That you have combined both.
Right.
Where is that? The grading chart. No, I asked it. No, you continue. Continue answer.
Very important points.
Yeah.
Vitals, pulse rate 92 beats per minute, normal rate.
Any abnormality here?
No, sir, I think it's not.
Okay. So which is the most important parameter for the child with obesity? Is a blood pressure. Okay. So here is normal. What is normal for you?
Systolic blood pressure at 90 to 110 and diastolic is 50 to 70.
This is normal. Right.
Anthropometry. Expected weight for age 25 kg, observed weight for age 51.5 kg, and percentage 206. Interpretation more than 97% indicates obesity. Expected height for age 126 cm, observed 141.7 cm, percentage 107. Indicates interpretation more than 97%. Indicates tall stature. Expected weight for age 34 kg, observed weight for age 51.5 kg, percentage 151%.
Wait. Suppose the height of this child is between 3rd and 10th centimeter. What's the diagnosis? This weight is the same, but the height is between the 3rd and the 10th centimeter. Then qualify short stature with the weight is correct, isn't it? We discussed with earlier we discussed about the exogenous obesity. So now we have to another child whose height is less. Endogenous obesity. What do you mean endogenous obesity? What are the conditions that you can have? Growth hormone deficiency. Right. Proceed.
So in the growth chart, you are making so many mistakes. You are not supposed to put circles and the markings. And you have written the name and the height and other parameters. Date of birth, nothing is there in the graph.
Back.
And the BMI, see this circling you are not supposed to do. Just put only dots. And there is no other details of the patient.
Name is not written. Everything should be complete. Right.
Expected BMI 15.4, observed BMI 25.6. So the interpretation more than 27th adult equivalent indicates obesity. Expected waist circumference 61 cm, observed waist circumference 71 cm. Interpretation between 19th and 95th percentile. Per abdomen examination, inspection
What is
shape.
it? Waist
What does
separation.
it show? What does it mean to you? It is high.
Obesity.
Obesity is there. What does this alert
Importance
you
of
to?
waist.
Metabolic.
They don't have metabolic syndrome. Okay, what's the normal waist ratio? Anybody? Waist normal waist ratio, male, female.
Restless point.
Okay, it's opposite, right? Right.
Per abdomen examination, inspection, shape of abdomen uniformly distended, all quadrants moves equally with respiration, skin over abdomen, nose valve dilated, wing sinuses, pulsation, visible peristalsis, umbilicus central and inverted, no striae visible, external genitalia is normal. Palpation, abdomen is soft and no local rising temperature, liver is palpable 3 cm below right costal margin, soft in consistency, round margin, smooth surface, non-tender, spleen not palpable, no other bones palpable. Percussion, liver dullness here at 50 intercostal space, liver span 13 cm, no shifting dullness or fluid thread. Aspiration, normal bowel sound here, other systems are within normal limits.
Okay, back. Anything abnormal here? So very normal in abnormality.
Liver span.
So let's have a look at hepatomegaly, isn't it? So child of obesity as well as hepatomegaly. So what should come to your mind? Yeah, this could be a non-alcoholic fatty liver disease we have to look for, right?
Summary: 8-year-old boy with complaints of excess weight gain, hyperpigmentation on back of neck, abdominal pain, history of snoring, mouth breathing, constipation, physical inactivity, with excess of 978 kilocalories, significant family history present. On examination, tall stature, BMI more than 27th adult equivalent, liver spans more than 13 cm.
And screen time 5 to 6.
Diagnosis: 8-year-old boy with exogenous obesity, tall stature, hepatomegaly indicates fatty liver, acidosis like grade 2, insulin resistance, obstructive sleep apnea.
Okay, so here the exogenous obesity because he is having a short life and there's a positive family history also. And then he has got hepatomegaly, so we should always suspect underlying fatty liver or the non-alcoholic fatty liver disease. Acidosis like indicate underlying metabolic syndrome, therefore we have insulin resistance. And finally, he has also got probably obstructive sleep apnea. Right.
Junks, we should avoid junks, junk food, ultra processed food, nutritionally inappropriate food, caffeinated, colored, carbonated food, sugar, and sweetened beverages.
Right. So how do you evaluate this child? And you can volunteer for going to the slides. So this child has come to us for fever. So we have complaints of the child and made a diagnosis of exogenous obesity. And probably having some other comorbidity like non-alcoholic fatty liver disease, acidosis, negligence. So how do you evaluate this child when you are sitting in lobby?
Fasting blood glucose first. Postprandial blood glucose level, HbA1c,
Okay.
triglyceride level, LDL,
So what is the are there? No, okay. So let them answer. So you have to go for the blood sugar. Then you have to go for a liver function test. Second. Third, fasting lipid profile. Always you go for a fasting lipid profile. Anything else? Yeah, always follow hypothyroidism. Second, because that's a curable cause. Also, always look for a free for a TSH. Second.
And he is having abdominal pain.
And he is an abdominal pain. So I have to look for a ultrasound abdomen. Second, and also look for gallstones. Second, so look for gallstones, assess the liver, and look for any evidence of virus. So these are the basic investigation we done in a child with obesity. And please remember, they will not come to you with obesity, they may come to you with some other problem. And you have to look for carefully other causes, other comorbidities like shift capital devices, broad disease, etc.
Here the abdominal pain is on the left lumbar area. You have to rule out the uric acid stone also. Left lumbar area.
Right. And suppose the child is having kettle food, what is important one look for, especially the child is having short stature. As we said, think of a syndromic condition. So what the important one look for kettle food examination? They will have short stature. They may have dysmorphism. Children Down syndrome, Prader-Willi, etc. So think of dysmorphic facies. Third one, look at the cognition. The cognition may be impaired. They may have intellectual disability. And above 5 years, we use the intellectual disability. Less than 5 years, we use the developmental delay. Okay, so less than 5 years, we use the developmental delay where cognition may be affected. Above 5 years, we take the diagnosis of intellectual disability. So short stature, intellectual disability, you always suspect a syndrome. Underfully hypotonous. Right. So we have done the investigation how to manage it. Slides and colors. Okay, how do you manage? One is exclusively continue breastfeeding up to exclusive breastfeeding up to 6 months and continue breastfeeding up to 30. Okay, then you read it. Okay.
Exclusive breastfeeding for 6 months. Introduction of complementary feeding at 6 months. Continue breastfeeding till 2 years. Age appropriate portion, size, texture, frequencies, variety, and active feeding. No juice, sweetened beverage, no added salt or sugar, no screening time. Keep active on food. Then preschool to adolescent. Diet 3 meals, 1 to 2 snacks. All meals on table. No sugar beverages. Parents as role model. Activity moderate to vigorous play 45 to 60 minutes per day. Screen time less than 1 to 2 hours. No TV or electronic devices in bedroom.
So what is traffic light in obesity? Traffic light model.
Traffic green. Green often taken fruits and
Green
vegetables.
stands for
Fruits and vegetables.
fruits. So you should take more amount of fruits and vegetables. That means they can be consumed in enough amount. So it is very safe. Second is
Yellow. Pulse and grains.
grains as well as pulses as well as lean meat. So which can be taken occasionally. So that's a caution, right?
Then red. Sweet.
Yeah. So red should be. Yeah.
And red.
What is
Sugar
red?
and sweetened.
Okay.
And all
Sweet
the junk.
beverages, sugar as well as high fat diet, isn't it? All your junk food should be avoided as much as possible. Okay. So always remember traffic light whenever you come across a child with obesity. Okay. And
Then pharmacotherapy. Oral step. It reduces the acid.
we said mentioned parents as role models, isn't it? So that means whatever you do, that should be for the whole family. Where if a one child is obese, the father or mother cannot take anything or everything fry and let food and force his child to eat other green foods only, isn't it? So whatever it grows, I think we should always implement for the whole family. Parents also cannot watch TV for 2 hours or see WhatsApp for 3 hours and avoid screen for the child. So always discuss with the parents or separate, isn't it? So take both parents in confidence and you should tell them that they should be the role models. So whatever that is cooking, that is for the whole family. And no one should watch the screen in the house. Then only that can be implemented to the child also. That's very important. Okay. Right.
Pharmacotherapy, all these data is given. It reduces the gastric lipase, decreases the fat absorption. If it's a diabetes is present, metformin is also given. Non-alcoholic fatty liver disease, we should give metformin and vitamin E, bioglutamine. For constipation, laxatives, lactose is given.
Young age we don't give pharmacotherapy.
Generally, we will not entertain pharmacotherapy, isn't it? Because this is exogenous obesity and we know it is suddenly happens and I cannot take. So we're going to go for pharmacotherapy. So practically speaking, we don't entertain pharmacotherapy in children, isn't it? Most of exogenous obesity and lifestyle modification with appropriate diet and exercise will be enough for them. And treat the whole family. And if it is endogenous or endocrine causes, you find out the cause and treat the endocrine.
What HbA1c is normal? Less than?
So metformin
No, we have to do dietary and exercise first. Don't
Don't
come with metformin for HbA1c.
Metformin can be given if there is type 2 diabetes.
He didn't have.
Or impaired fasting.
Yeah. But already one child is getting metformin.
Yeah,
500 milligram BD.
11 years old, we have diagnosed type 2 and we have started insulin. Now she's off. She's only on metformin.
So probably that's the only indicator to go for metformin. See, the child is having diabetes along with that.
HbA1c should be less than 5.7.
Now GLP-1 agonist is more commonly given than what is
16 years. That is, all these drugs are recommended only after 16 years. But we are still giving it below. FDA approval is only after
16 years.
every week we are seeing one obesity case in here. Overweight or obesity.
And so it's universal, isn't it?
It is universal.
So it should be exam case. Exam is
It should
invariable.
be exam case.
Invariably this
Obesity
will be
should be
exam
exam.
case.
I think in BNB now they are keeping.
Gents,
So what are the basic take-home messages? Whenever a child is coming with any symptom, please see whether the child is overweight or obese. Isn't it? Second, always find out the body mass index. Then, third, rule out hypothyroidism in all children with obesity because it is 100% correctable. Fourth, look for dysmorphism, look for cognition impairment, hypotonia, then you are what you will be leading to the syndromic condition. Screen family members and could be exogenous obesity. Remember the traffic light. Implement rules for the whole family, not for the child alone. Screen time, maximum 1 hour per day. Exercise, 45 minutes every day. And again, exercise also should be for the whole family. Okay, and diet restriction.
They should come back.
Green, red, green, yellow, and orange. Right? And always think of the comorbidities. They can have non-alcoholic fatty liver disease. They can have gallstones. They can have musculoskeletal problems. And they can also have psychological issues like poor self-esteem as well as even depression. Okay. So you should take them into confidence and manage obesity for the whole family as well. So thank you for that.
Obesity discussion. I think it was really an eye-opener. No? They don't come to you for overweight or obesity. We will have to pick them up and proactively treat them. Otherwise, they all end up with all the lifestyle diseases. Now we have. Thank you, President. That was an insightful I would like to call